for LB101, and we will now open the hearing for LB100. And Senator Walls, this is your bill as well. And so as soon as they change out the card here. Senator Walls, you're welcome to open on LB100.
Again. Chairman Archer, members of the Health and Human Services Committee, my name is Lynn Walls, L-Y-N-N-E-W-A-L-Z, and I represent District 15. Today, I would like to introduce to you LB100. This is the latest effort to ensure Nebraskans continue to be able to access healthcare services in our Medicaid managed care system. Last year, the Nebraska legislature unanimously passed LB956, which required the 3 managed care companies contracting with the state to communicate and work with healthcare providers when MCOs make changes to contracts that have substantial financial impact on the delivery of their healthcare services. Protecting access to healthcare for those in our Medicaid system is something that this committee has worked hard to maintain. LB100 stops managed care companies that contract with the state of Nebraska to deliver Medicaid services from implementing a payment policy that severely alters the ability of 3 types of therapy providers: physical therapist, occupational therapist, and speech and language pathology providers. The policy is called a multiple provider payment reduction, or MPPR. The policy reduces rates paid to providers when multiple procedures are delivered to the patient on the same date of service. This bill focuses only on these 3 rehabilitative healthcare services because these were impacted by the implementation of this policy by one of the managed care companies. I anticipate there may be other providers that are concerned that such a policy may be implemented for their types of services. We all know how low Medicaid rates are, and that those low rates have a dramatic impact on the number of providers that can no longer afford to provide services in our Medicaid system. Can you imagine the impact on your small clinic after delivering one service and getting paid at the full rate, then be paid significantly less for a subsequent service? Perhaps a larger facility can sustain that business model longer, but at some point, decisions must be made to cut those services. This is not a policy that can be sustained by providers, and one that we cannot let contractors of the state implement. There are several providers coming up behind me that will go into more detail on how this policy works in practice and the impact it has on their patients. Thank you, and I will be available to answer any questions.
Thank you. Are there any questions at this point for Senator Walls? Seeing none, thank you. Now welcome the first proponent for LB100.
Good morning.
Good morning. Welcome.
My name is Grace Knott, G-R-A-C-E, Knott, K-N-O-T-T. Senator Arch and members of the Health and Human Services Committee, my name is Grace Knott, but I currently am president of the American Physical Therapy Association of the Nebraska chapter. Our chapter has over 1,400 PT, PTA, and student members. I want to thank Senator Walls for introducing LB100 on behalf of all therapy providers. I'm here today in support of this bill. The association believes this bill will benefit Nebraskans by having a clean and concise method of payment for therapy services provided from all the current and future participants of Heritage Health. Currently, this is not true, as one MCO within Heritage Health applies a payment policy for therapy services that result in 10 to 15% reduction of payment for therapy services compared to the Nebraska Medicaid fee schedule. This affects all rehab providers as well as Nebraskans who have Medicaid for their health insurance. This will also have an impact on more Nebraskans with the recent Medicaid expansion. At first glance, you might see this as only a provider problem, but it may have ramifications for accessibility for therapy services in lower socioeconomic regions of metropolitan and rural areas, and finally, for our pediatric patients with developmental disabilities. In Nebraska, services provided to the Medicaid beneficiaries are paid based on Nebraska Medicaid fee schedule. This fee schedule is set at the lowest possible level, which in many instances are below the cost of providing the service. Therapy services are labor intensive, and the majority of services are paid based on time actively treating a patient and not, unfortunately, on the skill and knowledge of that therapist. Any reduction of reimbursement affects our ability to pay rent for office treatment areas, pay supporting staff, and to pay off the astronomical student loan debt that physical therapists and other rehab therapists incur as they pursue their calling. The physical therapy entry point is at the doctorate level. When private practice physical therapists investigate a location for their practice, they look at the local population and that they will be serving. As we well know, that for physical therapy, since we see them on a regular basis for a period of time from 2 to 3 weeks to 4 to 6 weeks, maybe twice a week, 5 times a week, we know that it needs to be convenient. So distance from your house or from your work to the therapy clinic is crucial. If it is inconvenient or difficult or time-consuming to attend a therapy session, the therapy prescription is not completed. With the knowledge that an MCO is paying below cost of delivering services, there is a high concentration in a particular area of Medicare beneficiaries. The private practice rehab provider will probably choose a different location. Therefore, a Medicaid beneficiary is left with driving longer distances to assess needed rehab services. Therapy services are left to large state institutions and large hospital systems to access therapy services. If a private practice therapist decides to locate their practice in an underserved area, they might limit the amount of Medicaid beneficiaries they treat at one time to keep their average reimbursement at a level that they may have an economically sustainable practice. This would delay the initiation of therapy services. Pediatric rehab practices are especially affected by declines in reimbursement for Medicaid beneficiaries that are below the Medicaid fee schedule. Over 3/4 of Medicaid CHIP children with special health care needs live in families with incomes below the 200% federal poverty level, which right now is at $42,660 a year. So again, many of these Medicaid beneficiaries have to drive longer distances to obtain needed therapy services for their children. They have limited resources and must rely a lot of times on public transportation, cab services, and other modes of transportation. With the lack of accessibility to needed medically necessary therapy services, which delay the start of therapy or complete lack of therapy, what are the downstream costs to healthcare in the future? Looking at a study in 2017, those who refer to PT within 15 days of diagnosis have downstream costs that are $3,500 less than those who receive therapy 45 to 90 days after the onset of acute back pain. For patients undergoing hip arthroscopic surgery, for patients that had physical therapy first before opioid use, there were significant less downstream healthcare costs and less opioid use addiction if therapy was assessed timely. Chronic diseases are effectively managed by physical therapy and other rehab disciplines, and lack of function is directly a result of muscle weakness, joint inflexibility, and poor endurance. I'm in the red already, which can be treated for effective plan of care here.
So since the red light has come on, I would ask that any concluding
Yes.
statement, quickly.
Never get past the red here. You have it in the testimony. What I want to stress is that this is a flawed policy, the MPPR. It originally was implemented for surgical practices, which it makes sense that a surgeon is in the room, everything is sterilized, and for the hospital, the instruments are there. If you do one thing, a a procedure to his shoulder and you do another thing for that shoulder, it makes sense that that second procedure should be paid less because the practice expense is less. But for physical therapists and all rehab professionals, our cost, it was already spread around 3 units of service or 3 different procedures. So it's been a flawed policy that my association has been vocal and trying to do advocacy since its inception by Medicare 7-8 years ago.
Thank you.
And I thank you.
Questions from the committee? Senator Kavanaugh?
Thank you. Thank you for being here. You stated that there's only one MCO currently.
That's
using
correct.
it. So is it fair to assume that providers then will not want to take patients that are covered under that?
That's correct.
Okay. So we're sort of creating a disparity amongst Heritage Health
Right.
clients.
They're not the same.
Okay. Thank you.
Senator Hansen?
Thank you, Chairman Arch. Thanks for coming to testify. I think I've heard you testify many times before here in this committee, and yeah, it seems like you get halfway through and that red light comes on.
I'm a little too
Don't feel bad.
verbose.
It's
I
good.
need to work on
Information is
that.
good. So essentially, it seems like, especially in your profession, we're paying for your expertise, right? It seems like that's what we're paying for, to get the patient better, to improve health outcomes, to be efficient with our care, and that's what we're paying for. And so when you do 3 services, say 15 minutes each, you're doing, your expertise is the same each one, right? I mean, there's nothing you're changing. You're not providing less service with the other 2 than you would with the first. And so it seems to me that it's hard for me to understand why we're not paying the same for each one. And so I think your argument seems valid when it comes to here, but I just want to make sure and reiterate and confirm with you that nothing is changing with each one of those services, right? Like you're
No.
doing the same pretty much thing.
No.
Okay, good.
No.
Thank you.
And it was already, how our relative value of each thing that we do was already spread across 3 units of service when they decided what each type of thing that we do has already said, well, it's part of 3. And so they reduced that amount anyhow.
Thank you.
Thank you. Other questions? Senator Williams?
Thank you, Chairman Arch. And I'm just reading through some testimony that we have been given to us that is in opposition to this legislation. And it seems to indicate that the billing process that you are talking about has been fixed and that's no longer going on. But from your standpoint, this is a current concern that is still happening today with one of the MCOs.
I will say that we have been advocating, and it was United Healthcare Community Plan. We have been advocating with them, have met with them multiple times over the last 2 years. In December of last year of 2020, they did verbally tell us that they were looking at not implementing the MPPR anymore. We have not gotten that confirmed yet. We have decided to go ahead. We feel this bill is still needed because we know new contracts come up and we don't want to have to fight again. I hate to say how many hours and meetings, and my other members that are here can tell you, we have met with United Healthcare multiple times and multiple hour-long meetings.
So there's been a lot of talk, but not implementation of that yet.
That's correct.
You have not seen billing changes.
That's correct.
Thank you.
Thank you, Senator Williams. Other questions? Seeing none, thank you very much for your testimony.
Thank you.
Next proponent for LB100. Thank you, and welcome.
Good morning. My name is Mary Walstrup. I'm testifying today, Mary, M-A-R-Y, Walsh, W-A-L-S-H-S-T-E-R-U-P. I'm testifying today in support of LB100 as a member of the Nebraska Occupational Therapy Association and on behalf of the Nebraska Speech, Language, and Hearing Association. I'm currently a practicing occupational therapist Here in the state of Nebraska and a partner at Central Nebraska Rehabilitation Services, a provider that provides PTOT and speech services across Nebraska. First of all, Chairman and the rest of the committee, thank you for allowing me the opportunity to come here and speak to you today about the MPPR and its effect on our practices here in Nebraska. As Grace just indicated, the MPPR, we believe, is a flawed plan because of our therapy codes are based on 15-minute increments provided sequentially. Currently, it is, we have worked with one of the MCOs, and currently they have suspended that practice. My concern as a practice owner is that if all three of these MCOs were able to provide the MPPR, we would no longer be able to treat Medicaid patients at our clinics. In recent years, the private practice section of the APTA put out some cost analysis of what it cost a therapist to provide a visit. Visits are based on, most insurance companies say that 4 timed units and 1 untimed code is a very typical therapy visit. And so if you figure 4 timed units are about 15 minutes apiece, you can assume that the majority of therapy visits are 45 minutes to 1 hour in nature. The cost to provide those, you can see in 2019 was $85.19. The PPS has indicated that that will probably increase this year by $5.22 due to the American Medical Association's application and study looking at all the additional COVID measures that need to be put in place. So I actually took some actual claim examples to show what's going on. So if you look at a patient, in example number 1, that had a post-hand surgery and receiving occupational therapy, they had 49 minutes of direct one-on-one care with the therapist. If they were getting the state-approved rate, which is what I call straight Medicaid rates, they would receive $72.42. One of the MCOs paid us $61.43, a reduction of $10.99 for that same 49 minutes. Another example would be a PT and speech claim. Here, the patient received 98 minutes of services, and the state-approved rate would have been 123.54, and what we actually received after the MPPR was applied was 99.90. You can see how if you added this up over a period of time and over a day, how this would dramatically affect what is occurring. You can see on that example too, realizing that statistically and research shows that the actual cost per visit is $85.19. In this example, they were receiving 2 services, so 2 visits. You can see how much in general, Medicaid is already at the bottom dollar for us to be able to provide these services. I provided 3 additional examples. So when performing Medicaid visits, Medicaid already requires more paperwork, more administrative burden. Medicaid already requires more paperwork, more administrative burden, more authorizations than any other payer out there, including Medicare. So when you add the MPPR on that, when you're already getting the lower dollar rates, it makes it not feasible and makes this for a practice that we cannot sustain. I'm from a large provider. We will not be able to sustain this practice if all the MCOs, and we were actually considering moving away from it. If you look at the Title 471 of the Nebraska Administrative Code, it gives specific guidelines that we as providers need to adhere to when providing Medicaid services, including that we are providing the least amount in the most cost-efficient manner to the therapist or to the patient. We, as therapists, believe that we provide this for the patient, and we were hoping that, the rate is already low. We feel it's right at about our cost. We're happy to do that, but we can no longer sustain going below cost. I'm happy to answer any questions about that.
Thank you. Are there questions from the committee? Seeing none, thank you very much for your testimony.